Good evening. My study is on proportion of dyslipidemia in patients with meibomian gland dysfunction in a tertiary care center. Meibomian gland dysfunction is one of the most common ocular surface disorder and a major contributor to evaporative dry eye disease. Changes in systemic lipid metabolism may alter meibum composition, increases its viscosity, and raising the melting point, thereby leading to glandular obstruction and progression of MGD. Understanding the relationship between both may help in identifying dyslipidemia as a modifiable risk factor for MGD and provide new insight into preventive and therapeutic strategies. So, screening for dyslipidemia in patients diagnosed with MGD allow for early detection and intervention, potentially improving both systemic and ocular health outcomes. My primary aim was to estimate the proportion of dyslipidemia in patients presenting with MGD in ophthalmology OPD, and secondary objectives were to determine the association between MGD and individual parameters of fasting lipid profile, to assess the effect of dyslipidemia on severity of MGD, to identify whether treating dyslipidemia causes improvement in MGD. The study population was patient of age group 45 to 75 years attending OPD in a tertiary care center, and study design was a cross-sectional analytical study with convenient sampling method taken 1.5 years, and the sample size was 50 patients. Inclusion criteria are all patients presented with MGD and not on any lipid lowering agent, and exclusion criteria were patient using medications which cause dry eye like tricyclic antidepressants, antihistamines, diuretics, beta blockers, patients on anti-glaucoma medications, patients with rheumatoid arthritis, Sjogren's, lupus, and patients with history of previous ocular trauma and ocular surgeries. Study variable include age distribution, gender distribution, slit lamp examination and staging of MGD, shimmer test, tear film breakup time, FLP including all individual parameters, and post-treatment improvement in symptoms. Coming to results, comparing age and clinical stages of MGD, higher number of MGD cases were seen between 60 to 70-year age group. Older patients tended to have more advanced stages of MGD, but the relation was not significant statistically, but age remains a background risk factor for MGD severity. Comparing gender and MGD severity, both genders were affected similarly across all clinical stages, and gender was not an independent factor influencing the severity. Coming to total cholesterol and MGD severity, 64% of the participants had high level of total cholesterol, suggesting that most of the participants in this research had elevated cholesterol level, which may be linked to severity of MGD. A statistically significant association was found between total cholesterol level and severity. As the total cholesterol level increased, MGD severity also progressed, with all stage 4 MGD patients having high cholesterol levels. Comparing LDL and MGD severity, 58% of our participants had high LDL level, but the p-value shows is borderline statistical significance, suggesting large sample size may show stronger significance. Triglyceride and MGD, 76% of the participants had normal triglyceride level, suggesting that variations in triglyceride level may be present in individual with MGD, but it alone may not play a determining role in disease progression. HDL levels were high. 76% of participants had high HDL levels, while 24 had low HDL level, but there was no any statistically significant correlation. VLDL and MGD, 76% of the participants had normal VLDL level, and no statistical significant association was found between VLDL and MGD. Tear film breakup time was abnormal in all study participants, and shimmer test showed a decline in value with increasing MGD severity. Conclusion: the study demonstrated a high prevalence of dyslipidemia among patients with MGD, with total cholesterol showing a statistically significant association with increasing MGD severity. Elevated LDL level also showed borderline relationship, whereas triglycerides, HDL, and VLDL did not correlate with severity. Age and gender were not significant contributors. Hence, my study suggests that systemic lipid abnormalities, particularly hypercholesteremia, play an important role in pathogenesis and progression of MGD. Therefore, routine lipid profile screening in MGD patient is recommended, as early detection and management of dyslipidemia may help improve both ocular surface health and overall systemic outcome. Further longitudinal studies are needed to establish causality and assess the benefit of lipid lowering therapy in MGD management. Limitations were small sample size, a cross-sectional study design, and a single-centered study, which may introduce selection bias and limitations. And diagnosis and staging of MGD were based on clinical examination rather than advanced imaging techniques like meibomography. And the follow-up duration was very short, and the study did not evaluate long-term effect of lipid profile management on MGD patients. Since the study duration was limited, it was difficult to study the effect of lipid lowering agents on reducing severity of MGD. These are my references. Thank you.
Nicely, you have brought out most of the factors, and you have also brought out all the handicaps which you have. So we'll advise you to work around it.
What is your hypothesis behind this? Why raise serum lipids should lead
Because
to MGD?
MEIBOM also contains lipid components. So while there is increase, if there is increase in systemic lipid level, there can be alteration in MEIBOM composition also, which raises the melting point of MEIBOM and decreases the normal secretion, clogging of meibomian glands.
Okay, so, unless it's an abnormal lipid, it's not going to cause MGD.
Lipid
Okay, you can
also
explore.
occurs. Lipid
But
also.
anyway, this is a nice study. Half of the time we don't know why MGD is there. This could be one factor. Thank you.